Good morning, everybody. Right at around 9 o'clock, we're gonna get started. February 13th, welcome. Union Hospital Audit Review. We're going to start off with the STEM report with Brenda Williams.
Good morning, everyone. I'm Brenda Williams. I'm the manager of inpatient telemetry here at 2 East Day here at Union, and then I'm also the chest pain coordinator. All right, bring me the STEM report. Well, I don't mess with it.
You need to move that.
Oh, yeah.
Just make it smaller.
So we start at 1:02 in the morning. EMS was dispatched from the med base in Knoxville to a residence. By 1:19, they arrived to find 57-year-old male sitting on his couch. He was complaining of chest pain that started 1 hour before. He was peaked, patient was peaked, warm and dry, pupils were active, no JVD, blood bases were cleared, equal, no pedal edema present. Patient was awake and alert with ECF of 15. He had a history of hypertension and he was a really heavy smoker. Patient already on 2 liters per basal cannula via the Rosedale fire, which was right there before them. They were starting at 99%. And they also already gave him a 324 milligram aspirin. By 1:21, 12 lead was obtained showing an inferior STEMI. Patient reports taking Viagra 2 hours prior. By 1:30, vital signs were 153/86. Heart rate of 90, respiratory 18, and he was 99% off the 2 liters. E-bridge STEMI alert was sent. They did say, however, the e-bridge STEMI alert had to try to be sent and they had to wait until they got further down the road. So they eventually did it. They attempted to call medical control, but no signal, and they were out of line for the by 1:45, saline lock was started the left forearm with an 18 gauge. Labs were drawn and fasting blood sugar of 73. They gave him fentanyl, IV push, 50 micrograms times 2 for his chest pain, and he rated out of 6, and he said he had no relief with that. By 1:59, they had arrived at Union. By 2 o'clock, they'd already come in and got another 12 lead EKG. Here's the EKG that we got at Union. I didn't see the one that came to campus, so.
You didn't see one? I'll have to look at it.
Yeah. By 2:13, the ED physician discussed the case with cardiology and they agreed with the impression of a STEMI, so they activated the cath lab. Cardiologist recommended them giving a 4,000 unit bolus of heparin prior to cath lab. By 2:24, chest X-ray was obtained, suggestive of mild vascular overload with mild cardiomegaly and mild vascular congestion without frank pulmonary edema. By 2:48, patient arrival to the cath lab procedure room. 3:13, percutaneous coronary intervention of balloon catheter advanced to target vessel and inflated. Successful percutaneous coronary intervention with dry eluting stent to proximal to mid RCA, taking 100% stenosis to 0. Noted that the patient had severe residual stenosis in the proximal left circumflex artery, which would require intervention during the submission. So they did end up, you'll see the door to balloon time was 74 minutes for his STEMI. He did go to ICU, and then he went back to the cath lab for a successful PPI with a drug-eluting stent to the proximal and mid-left circumflex artery. They did do everything by TR band. Patient educated on the importance of being compliant with his medications, especially aspirin and Brilinta. He was counseled on smoking cessation with a nicotine patch discharge. He'll have labs repeated 2 days after this stay and follow up with his PCP, and he will follow up with his cardiologist in 1 to 2 weeks. He was discharged 2 days after a STEMI. So, I mean, that was a pretty good quick run, and all about that in 2 days time. Now, just give me light with his medication. That'd be great. There's our door to balloon times for 2023. We ran 88% for the year. Had a few dips. You can see January, February, and then of course July didn't look so hot. But we're back on track. So thank you for all you do.
Thank you, Brenda. Appreciate that. All right, next up is going to be Beth Harrison. She's going to have our stroke report.
Morning, everybody. I do have our strike report. The technology.
About the other.
And the other, it was a 16-year-old female that lived in an assisted living facility. She had just returned from a physician's appointment and developed sudden onset of left-sided weakness and generalized lethargy. She lost her balance and fell on her bottom, no injuries. When this was going on, she had confirmed onset of blurry double vision and a loss of her peripheral vision. And it is arthria that resolved before EMS arrived. The EMS run, the call was received at 09:49, dispatch at 9:52, en route at 9:53, on scene at 09:57, departed at 10:13, and we arrived at Union ER at 10:20. In the emergency room, at 10:37, the CT of the head was complete without contrast. We call it CT stroke. No bleed was present. The NIH was completed by the MD with a score of 6. At 10:04, the CT was read. At 10:26, teleneuro was consulted. At 10:43, T&K was ordered, administered at 10:54 with a door to needle time of 29 minutes. So excellent work by our ER team. Whoops. Part of my.
All right. Oh, that's
Well,
probably.
I'll just tell you about it. How's that?
That's probably my fault because I changed it around.
It's true. I try to do this from home and I should never use my home computer to try to do this because it always goes crazy. But this patient, she did come in, after the CT and everything was completed in the ER, they did go ahead and did a CTA because our NIH was 6 or greater. It did not show a large vessel occlusion, so there was no need to ship her anywhere. She was admitted to the ICU for observation, and the 72 points of vital signs post documentation was completed on her timely, so we did a great job with that. Our in-house hospital neurologist saw her. They did an MRI the next day. She was negative for a stroke. He felt that she did have a posterior circulation TIA due to the onset, the loss of vision, and all the other things that went on with her. She had some ataxia because in the EMS documentation, she was leaning to the side. So she was very lucky. She was able to return home with her family. She was able to return home, with physical therapy and some speech therapy at home, back to assisted living. Some of the really good things about this case, the stroke alert was called, which gives our ER team a great heads up. She went directly from the cart to the scan. The patient called EMS emergently. As soon as this happened, she didn't wait around thinking, oh, it's going to get better. She did call emergently. Cincinnati stroke was completed. It was very good documentation by EMS. It told a great story. I could tell exactly what everything that went on, and it was all very followed the protocol of a stroke. And our processes worked really well in the ER. So overall, we handled this process very well. And this lady was lucky; she had a TIA. And the one thing that they did change on her, I don't have it on here, was that her home medications. Our Dr. Pidgeon, one of our hospital neurologists, felt she was on Celebrex for her arthritic pain, and that gives an increased risk of stroke and heart risk. So he took her off that. She was on low dose aspirin, 81 milligrams already daily, but he did put her back on the Plavix, so we did the concurrent therapy there to prevent the further stroke. And if that doesn't work, of course, our next step will be like Xarelto or one of our Eliquis. So people watch on her. So any questions about anything? Sorry, some of mine was missing, so I just tried to.
Yeah, that's probably my fault, because I took her presentation, put it into the template, and I think it messed it up, so.
Yeah, it happens. No worries. If you guys have anything about stroke, or you have any questions, I'll be glad to answer them. Thanks.
Thank you, Beck.
Thank you.
Next up is gonna be Union Hospital Clinton, and Kale is on. Kale, I will move your slides for you, so.
Hey, good morning, everybody. It's been a minute. Actually, Barry, I'm filling in for Will. Will put this together. It looks like Will kind of stole a little bit of Brenda's thunder here. So this is the same case study that Brenda.
Oh, wow.
No. It's the same case study here. So Barry, I'm going to have you advance like 8 or 10 slides to case study 2.
There you go.
There we go. So we always try to pull like one that's kind of cardiac and one that's kind of neuro, and then try and meet both of our referring agencies up here. So try and pick somebody from Park County and then somebody from Vermilion County through Illinois here. So this case study is around the neuro kind of time frame. We had a 57-year-old female. She called 911 from her vehicle, which happens a lot up here in the sticks. She was heading to work and was starting to have some numbness, tingling on her left side, but she did have a prior CVA there. Go ahead, Bear. So EMS was notified a little after 11. They arrived on scene locally pretty quick. They departed scene and then were here. No real notes in the actual ESO documentation as to why there was an extended arrival time, but there you have it. Per the run report, they found her there at work, dispatched for that possible stroke. They found her in her vehicle, stated she didn't feel right. She kind of walking on air, had a history of anxiety. She had taken some Xanax for that. Assessment wise, GCS was normal, Cincinnati was negative, completely alert and oriented, able to kind of stand and transfer to their stretcher. Vitals were largely within normal limits, kind of in line with her prior history of anxiety. 12 lead was inconsequential. She requested transport here to UHC. They called that in via cell phone, as happens up here when the radio is not working. And then she was able to scoot over to our bed from the EMS stretcher. She arrives in the ED. A stroke alert was finally called about 15 minutes into the patient's stay. I think Will had talked to the staff about that, and there were some differing opinions on whether or not that would constitute a stroke alert or not. But she was taken promptly once the stroke alert was called to CT. Glucose was fine, neuro did a consult, her Torbas was negative, not recommended for TNK or thrombolytics of any kind. And then this is where it gets interesting, and I think this is why Will kind of highlighted this case, because this highlights where we're at in emergency medicine now. This patient didn't want to be transferred. This patient kind of wanted to go home. She had some family issues that she needed to take care of. And then we were unable to timely transfer this patient. So she refused EMS transport and decided that she was going to make arrangements on her own to get up there. And she did. She transferred via family up to Carl across state lines. Highlights, good things. EMS, exceptional documentation, pre-notification. Again, we have to use those cell phones up here, particularly Julie, if you're still on Park County. They have to do that a lot. That particular route coming in on 41 down to Clinton through Park County, it is just a black hole for iHern and 800. And then clear documentation of last known wells. I believe it's the same for EMS, and Beth, you can chime in here. We need that very specific last known well, like earlier today or upon awakening in the hospital, just doesn't count for us. They're really drilling down that we need like hour and minute kind of documentation. And that was put forth by EMS here. So good work on y'all.
EMS is doing a really good job with that with stroke too. I've seen they're putting the year, the date, and the time. So doing a really good job.
Kale, thank you very much for your presentation. Doing that.
Awesome. Thank you, guys.
All right. Next up is going to be Tina. She's going to be doing our trauma report.
Good morning. Okay, so this first case study is a 61-year-old female. Call was for oxygen-related fire with injury. 911 call 0043, dispatch 44, en route at 44. On the scene at 0056, departed at 0135. and at Union at 1:54. I called dispatch was a minute, dispatched to route 0 and route to arrival was 12. On scene departure, 38 minutes. Departure to arrival in the ED was 22, so the total 911 call to arrival in the ER was 73 minutes. So the EMS report, they were dispatched along with the fire for a burn. On arrival, the patient was alert and oriented, sitting on the couch in obvious distress with burns noted to her face. She'd lit a cigarette while wearing her oxygen of 2 liters. They had her on, fire had put her on 6 liters. She was sat 90%. Her hair was singed. There was swelling, redness, peeling around her eyes, on her forehead, and kind of across her face. Nose was completely black and nares were filled with soot and singed hairs. She had significant increased work of breathing with shortness of breath. Decreased breath sounds bilaterally, some wheezing. At 0106, her blood pressure was 172/91, pulse was 112, rest were 28, sat was 90% on 6 liters, GCS was 15. So they started IV and monitored, did a continuous neb, and sat increased to 100%, but they decided to go ahead and intubate her because of the increased work of breathing. And the patient was agreeable to this, and EMS did a really great job of documenting what her skin looked like, and that the discussion they had with the patient about why we need to do this. So that was really good. They gave her an IV bolus, RSI meds, put 8 ET tube in. Her end-tidal was still in the 80s and 90s, so they put her in vent. Vitals post intubation was 154/82. Heart rate was still 140. 14 on vent. CO2 was 59. GCS, of course, was 3 because she was sedated. I heard transported to Union ER. So she met a level 1 trauma activation for several things, but mostly the respiratory status. But any patient with injury has that's intubated or has assisted ventilations is a level 1. Anybody with respiratory insufficiency. So, and the burns greater than 20% and or respiratory distress. So she met for a level 1. The pre-arrival note to ER 153 burns to face and airway. Vitals were 135/90, 100% on the vent, 30% FiO2. She arrived at the ED at 0203. Brought in by EMS from home. Inhalation burns after smoking with the O2 on. Heart rate at that time was 127, 18 on the vent, 30/90, 100% sat. She's unresponsive, intubated, sedated. Obvious oropharyngeal trauma and burns submitted to the patient's oral and nasal pharynx. She was accepted by Eskenazi at 02. Well, CBC, they did usually EEGs, X-rays, ABGs. CO2 was still pretty high, but probably better than what it was. Chloride was 90, CO2, lipase 21, trope was 9. Chest X-ray showed placement of the ET tube, and KUB, they had put in a gastric tube. IV fluids, fentanyl, drip, IV Versed, diagnosis burns, airway trauma, and she was transferred to St. Vincent via stat flight as 0350. Anything? MS did a really, really great job with documentation, so thank you all for that.
I was gonna ask, do you guys have trouble finding burn beds sometimes? I know they're at a premium a lot.
Not
No,
so
we
much,
don't.
yeah.
It's the general trauma that's really bad.
Yeah.
We usually get priority over that stuff. They usually don't divert.
Gotcha.
I wasn't anything other than EMS, really good documentation. So the second one is, this one was from December. Is a 37-year-old male with MBA with injuries, 911 call at 1736, dispatched at 1737, en route 1738, on scene 1742, depart 1757, and at Union ER 1804. Called dispatch 1 minute, dispatched en route 1 minute, en route to arrival 4. They were pretty. On scene departures 15 minutes, departure to arrival in ER 7 minutes, total time was 28 minutes. On the EMS report, was dispatched for an MBA with injuries. Patient was on a 4-wheeler, ran into a parked car going pretty fast. Lying supine on the road, and the engine company was evaluating him. Didn't say whether he had a helmet on, probably, I'm sure he didn't, but swelling and deformity in the left jaw, left eye, bleeding from his ears. He was responding to painful stimuli only. C-color was applied, placed him on black backboard, and secured his head. Vital 107/65, 166 heart rate, plus for 41, SAT was 88, GCS was 8. Started 2 IVs, vital signs monitor, Versed. Bagged even respirations were 32, and SAT was 94. Called an IHER and transported to Union ER. Pre-arrival note, MBA with the 4-wheeler hit parked car going 50 to 60 miles an hour. Smelled of alcohol, Versed. They gave him Versed. Was responding to painful stimuli only. Level 1 activation was called. He arrived in ER at 1809. Vital at 98.6, heart rate's 151, rest was 37, 92% bagged, 10% or 100/75 blood pressure. His fast was negative. They intubated him, put him on the vent, did the labs. His alcohol was only 26. He did positive for meth. He had paraorbital hematoma on the right, laceration note on the left side of his face near the eye, bleeding noted from the right ear canal. He had flail chest, practice, A4 breath sounds. So, ER put in 1 chest tube, the trauma surgeon put in, I think they put in the right, the trauma surgeon put in the left. They got 300 out of the left, 300 of blood, 50 on the right. They did initiate MTP. His pressures dropped, this made me laugh, dropped from 150 or 120 systolically to 80 systolically at the NIDAR, I think that's how you say it. But it stayed between 90 and 100 throughout. His heart rate came down from initial 140s to high 110s, because I had to look up NIDAR. I didn't know what that meant. So I learn a new word every time.
Well, I will share that knowledge with the rest of.
Oh, I'm sorry, it means the lowest point. Lowest point, yeah. I figured y'all were way smarter than I am. But no, I didn't know, it was the ER doctor knows that, I just thought it was fun. So white count was 21.6, hemoglobin 11.7, GAP was 23, ALT 652, AST 861, and creatinine was 1.20. ABGs were still kind of poor, 7.207, PCO2 47.1, PO2 231, bicarb 18.7, base XS was -9, SAT was 100%. His chest X-ray showed bilateral interstitial opacities, worse on the second chest X-ray. Subacute emphysema worse on the second chest X-ray, mediastinal prominence widening. They gave him fentanyl and propofol drip, IV antibiotics, tetanus, normal saline bolus. Started a femoral central line, mostly for placement or for transport. Diagnosis was ATV accident, multiple rib fractures, right pneumothorax, left hemothorax, acute respiratory failure, closed head injury with loss of consciousness, periorbital hematoma, traumatic hemorrhagic shock, mediastinal widening, AKI due to trauma, liver cell injury due to trauma. So he met criteria for thoracic surgery, but at the time we didn't have thoracic surgery support here. So there was a decision made to transfer him to IU, got a bed at IU Methodist, and he was transferred at 1930 via Lifeline. Total ER time was 121 minutes. So it was a great job by ER and really good job by EMS to get him here very quickly. They weren't too far out, so it's best just to get him here, not take the time on scene to tube him when they could get him here real quick. So any comments, questions? No? All right, thank you.
Thanks, Tina, appreciate it. The next up, Zach's gonna do a talk on push dose pressors, just to let you guys know, we are going to be adding that to our protocols. And so with that note, I wanted Zach to talk about it a little bit. So a lot of people didn't know we were adding that. That was an advisory thing we kept for a while. So. Just worried about. Oh, gotcha. Just okay.
So yeah, so we are
Dr.
gonna,
Worley, sorry, I just said Zach.
we are gonna add the push dose pressors hopefully over the next couple of months to our protocol. So it's still, kind of a little bit of work in progress. So if anybody, Dr. Gosel, anybody has, comments, concerns, we can certainly still, address them in the protocol before it's rolled out 100%. But first of all, kind of what is a push dose pressor? So essentially it's a vasopressor medicine that instead, you normally give it in the continuous infusion. Instead of doing that, you give it through a syringe with an intermittent bolus. So you're not, it's not a hanging drip, it's an intermittent bolus of a vasopressor. So why did we think about doing this? Well, first of all, typically can be faster than, setting up an infusion, figuring out the drip rate, all that sort of stuff. Also, it will have usually a faster onset of action than a continuous infusion, but the drawback to that is it will have a shorter duration of action usually. So you'll have to redose it potentially, it wears off. So what about the history of the push dose pressors? So they've been used for decades in anesthesia. Anesthesiologists use them to kind of help keep patients' blood pressure up around, the time of intubation and during surgeries. But usually they use phenylephrine, which has less side effects as far as like tachycardia and that sort of thing, or ephedrine, which is kind of a long-acting epinephrine essentially. But over the past decade or so, they've become increasingly popular in emergency medicine too. So why do we use them in emergency medicine? A lot of times we use them to treat septic shock. Somebody comes in infected, blood pressure 60/30. You can give them a little squirt of epinephrine, get their blood pressure up while you're then, doing your fluids and getting the continuous levofed going and those sorts of things. But again, the caveat with that is it has to be done in conjunction with fluids, preferably after they've gotten, some appropriate amount of fluid in those circumstances. Same for ROSC. If you have someone that, you get back after a cardiac arrest and they're very hypotensive, you can give them a little push dose pressor cautiously while you're getting the infusion set up. Anaphylaxis is another reason why, someone you give IM epi to, maybe they respond a little bit, then get very sick again. Push dose pressors are good in those circumstances. I think, Dr. Yalzo, I don't know, in your practice, in my practice, the bottom one is really what I use it most for, is for those patients who are getting ready to intubate, who maybe have a soft pressure, their pressure is 80 or 90, and you're going to give them etomidate or maybe even ketamine, and you're going to paralyze them, and that's going to cause them to become more hypotensive. These are excellent patients for push dose pressors because you can give them a little squirt of epi or whatever you have and kind of boost their blood pressure up, and then you've got enough time to get them intubated and then address any hypotension that comes after that. So do push dose pressors, basically, I can't read what I write up there. Do push dose pressors take the place of adequate fluid resuscitation? I think is the essential question up there. And again, the answer is no. So if you've got a patient that needs fluid resuscitated because they're septic, neurogenic shock, whatever, it can be in your armamentarium, but those patients still need the appropriate amount of fluid as well. So what push dose pressor are we going to use in our system? We're going to use epinephrine because it's the most widely available for us. And again, just a little background on epinephrine. It's a synthetic drug that mimics endogenous epinephrine or adrenaline, which is produced in the human body by the adrenal glands and is also a neurotransmitter. Again, epi is Greek for above, neph is Greek for kidney, so it tells you it's created above the kidney and the adrenal glands. And again, it's also a neurotransmitter, and of course we know it as the fight or flight sort of hormone. Epinephrine is, when you look at what we call the adrenergic receptors, You have alpha and beta adrenergic receptors, and epinephrine hits all of them. But what we're most interested in typically is the beta effects of epinephrine because it will increase your cardiac contraction force. It will also increase your heart rate, which sometimes may be good, sometimes may be bad. You know, it just kind of depends on if the patient's tachycardic or not. And it's got a host of other things too that make it helpful, like in anaphylaxis by increasing vasoconstriction, bronchodilating, you know, those sorts of things. So the onset of action is a minute. So you give the push dose pressor, you know, you should see an effect within a minute, but it's going to wear off by about 10 minutes and maybe even a little bit sooner than that. So you may need to redose. Side effects, well, obviously it can cause hypertension. It can cause tachycardia. That's kind of a big one, you know, an important one to think about if you've got someone that's super tachycardic, you know, if you really want to give them another, you know, jolt of epinephrine, but you may in the right circumstance. And then it can be arrhythmogenic just from the tachycardic effects. So how to prepare these, and there are a couple of different ways. I don't know that there's one single right way, but basically you take a 10 milliliter syringe, you add 9 milliliters of normal saline and 1 milliliter of the cardiac epi. So you use the cardiac, not the anaphylaxis epi. So we'll see if this works. This is an option for how to prepare it. And basically, you have all the supplies there. You could use a pre-filled saline, or you can draw up the saline. You can put a stopcock on, and then basically move the epi from the stopcock into the 9 milliliters of saline. Now, I will say stopcocks confuse me. By the time I figure out which way to turn the stopcock, the patient will probably already be dead. So if you are a stopcock connoisseur, by all means, if this works for you, that's fine. It doesn't work for me. So I use kind of a little different method, which I don't have a video for, but basically I take a 10 milliliter saline flush and I push out a milliliter of saline. And then I draw the plunger back to the 10 milliliter line. So I got a little space up there. And then I remove the needleless adapter from the epi. Or sometimes what you have to do is actually put a needle onto the end of the epi, because sometimes this little plastic piece won't let you get the needle part of it into the syringe. And then I inject a milliliter of the epi into my 10 cc syringe and I mix it up. And label it, of course. I have to say that. Another option, you can make an infusion, sort of what looks like an infusion, and then pull out 10 milliliters at a time. And you do this by taking a 100 milliliter bag of normal saline. And then you have to take 10 milliliters out of the normal saline. And then you inject the entire cardiac epi into the bag of normal saline. So then you can have a volume again of 100 milliliters. And then you withdraw 10 milliliter syringe and you have the same concentration as if you do it the other way. I just usually don't have a 100 milliliter bag available, so I do it the second way. But regardless, if you do it, all of your options will result in 10 micrograms of epi per milliliter in your syringe. So what are the contraindications? Well, if you have an allergy to epinephrine, which is really not possible because your body makes epinephrine every day, we're not going to use it in trauma, right now, or pediatric patients. But those are really the only absolute contraindications. Relative, again, tachycardia, hypertension, chronic kidney disease, because epinephrine can really cause vasoconstriction of the kidney, so you want to be careful in that circumstance. But I would call it more of a relative, not an absolute contraindication. So again, each milliliter is going to have 10 micrograms of epinephrine. And so you can give anywhere from half to 2 milliliters about every 5 minutes or so. Again, for a goal systolic greater than 90 or MAP greater than 65. So 0.5 to 2 milliliters every 5 to 10 minutes. I usually always start with one, maybe two, if they're super hypotensive. If you give 3 doses, so if you're up to that, what would that be, 10, 15-minute mark or so, then you would consider a continuous infusion, but honestly, by that time, you may already be where you need to be. Some caveats on push dose pressors, so there's really not any great, evidence on them, about like the best dose, the timing, everything's kind of conjecture, just case study, that sort of thing. I think the biggest problem is, there's human error potential if you don't mix it right, you're in a high stress environment, those sorts of things. I mean, the best practice is to have pre-mixed syringe labeled by pharmacy, but you really have to have a high volume of doing this to make that worthwhile. And I don't think, outside of trauma centers and level 1 trauma centers and that sort of thing, that you really will get that kind of volume. And then again, you want to be sure that you are giving people the appropriate fluid resuscitation. A study in 2017 showed that over a third did not get the appropriate fluid resuscitation when push dose pressors were used. So this is kind of just what we put together as a protocol, just kind of goes through what we just talked about. And that is it. Any questions, comments, concerns?
Once mixed, how long is it good for?
I would not use it, I would just use it for that run.
Okay,
I think it's a very,
Pre-packaged, ready to go.
yeah, no, so I mean, I think if you were going to a run and you knew it was gonna be, something where you might use it, I mean, obviously that would be fine to do it a little bit ahead of time, but otherwise I would just, do it immediately before and get rid of it immediately after. A pharmacist may be able to weigh in a little bit more on that, but
If it was me, I'd want to make sure I mixed it up with my own eyes, not trusting somebody else's, that's honestly.
Thank you. Appreciate it. Well, I was able to reach out to Dr. Yazel. He's our state EMS medical director, and he agreed to come and speak to us today, give us some updates on the state. And great.
Appreciate it. You want to talk about one, nonetheless, it was fun too. Okay.
Here, this button here.
That's fine.
Yeah.
I'll forward it back. All right. Thank you, guys. Appreciate you having me here today. This is my favorite thing to do. I like to get out and about, talk and hear what's going on. I end up learning as much as from all these visits. I like to hear boots on the ground, what you guys are seeing and things like that. It's awesome. I'm pretty excited about there's not a lot of places I think that have pushed us in there. And I'm a huge advocate for it. Sounds like from those case reports, you guys are doing RSI out there. And I think that's one of the biggest mistakes we do out, in emergency medicine is not optimize conditions before we RSI. I fully support RSI, but what you're doing is taking away every natural physiologic response the body has to whatever stressor is making you want to intubate them. So they get unstable very quickly in the peri-intubation period. And you got to do it, I get it, but you want to make sure you optimize those conditions. And that's where I think push dose pressors are worth their weight in gold. That's where I utilize them most. The other one, I probably shouldn't say this out loud, but I do it sometimes if I want to get somebody over to CT and I'm a little nervous about sending them over there. I'll give them a little hit and be like, all right, let's get them real quick over there. You never want anybody coded CT, but sometimes it's like you need that answer to figure out what the hell's going on. So I do use it in that scenario too. But yes, anyway, that's great. I like that. Well, I'm not one that just likes to hear myself talk, so by all means, interrupt, fire out questions, comments, anything. My goal is for you guys to walk out of here today with any question or any feedback from the state level that we could be doing different, better, anything like that. So, I'll tell you what's going on from our end, but I want to hear more what your questions are, what you guys want to know, and things like that too. So, first thing, I know you guys probably already know this, but pretty exciting news. We're actually our own division now. We're a division of EMS. We used to be under the state fire marshal. So that's a big thing for several reasons. Number one, just from a morale thing. We always make the joke, we're the stepchild of the first responder services and things like that. Obviously, we still have a very tight relationship with all the fire services, but it does say, hey, we're our own standalone agency now, and that matters. It also matters from a funding and advocacy side of things and things like that. So this was a big deal, probably one of the biggest changes we've had in the last few years. Along with that's coming some planning, some other things as an organization. So really excited about that change. And so part of that, we're doing what's called EMS Vision 2025. And we're having these forums to say, okay, now, you got your own division. Now what? What are you going to do with that? And so we're planning like where we're seeing EMS going over the next few years and things. So we're having meetings about once every month or so. We're meeting tomorrow actually, for about 6 hours to kind of just inventory all the things that are going on with EMS, how we're gonna address those and things. And we have a lot of people from all over the state coming in and weighing in. It's not just an inside 465 thing, I promise. We got people coming from all over, so we're getting some good input, so. These kind of things, legislation stuff used to be on like auto delete on my emails because I'm like, I don't know how it works, you know, I don't know what happens up there in Indianapolis, but when you're talking about fixing some of the long-term systemic things in EMS, we have to be involved here. And I think that's why we've fallen behind over the years sometimes, is we didn't always approach legislative stuff with a unified voice. You know, we'd have like the EMS union and kind of the fire service and, you know, all the different, you know, things asking for certain things, but not everybody was on the same page. That has really changed over the last few years, and we've been much more effective on getting some of these things fixed that we've been clamoring about for a really, really long time. And even right now, like this, again, you probably don't know, this legislative session is one where they kind of even said going into it, we don't really plan on doing anything. Because I guess last time was a really big budgetary session. It went way over. You know, they're arguing about everything, a lot of drama. They're like, man, we just kind of want to get in and out. We don't want to address a lot of different things this time around. Even that being said, we have some really important EMS bills. This one right here, it doesn't seem like much, but so EMS is considered an essential service in 13 states. There is one state that didn't attach any kind of funding mechanism to that. You guys can guess which one that might be. Our great state of Indiana. Now, some places basically attach like license plate fees and things like that. So they have a budget to support all EMS related activities. You know, Indiana, it's been like this for a while, but we're trying to figure out, okay, you know, we're essential, so what does that mean? And every once in a while, we'll have this where somebody says, you know what, our county is not gonna have EMS, you know, a month from now because of, you know, something fell through, this and that. And we're like, but you have to, it's an essential service. And they're like, or what? And I'm like, or what? Like, we don't really have any, like, there's no recourse for that. And we're not looking to be heavy-handed, but we wanna say, okay, you know, you as these individual parts of the state need to support EMS. I mean, just like you do the fire service, police service, and things like that. This is a very initial step, but I think it's really more important than people are realizing. And basically it's saying that every county has to submit a plan for their EMS coverage. So what do you do? Like, you know, so you say, hey, you know what, I called EMS for my grandma, you know, just as a regular citizen, I called EMS for my grandma and it took too long for them to come. I wonder what our county's doing for EMS. And you guys know where you find that? Can't, like hardly anywhere. I mean, there may be some counties that are very transparent on that, but in general, you know, there's no public transparency on what EMS looks like. You know, you have to bend some ears on different people in the community and things like that. That's all we want to know is what are you doing in EMS in your county? And the other thing is, you know, and one of the reasons I think EMS has always struggled is there's not a lot of who is accountable for providing EMS. You know, is it your county commissioners? Is it, you know, who says, okay, we need to have EMS for this area? You know, this says at the county level, you know, whatever service you have. I always say there's 92 different counties, there's 92 different ways we provide EMS in Indiana. And I like it because it's not one size fits all. But somebody needs to say, okay, this is what we do in our county. And there's really no, you know, and so what they're gonna do is take those, compile them into a report. And as a state, we're gonna look at that and say, okay, where are we at in these different counties and things? What I think is important that a lot of people aren't realizing is there's some accountability there. Like say again, you don't like it that it took too long for them to come get your grandma and you pull up and you look at your county hasn't spent $1 on EMS in the last 5 years. And the next county over is given $1 million subsidy and has a great looking service, shiny new trucks. Guess who's gonna be on the other end of a phone call? You know, and so that accountability is gonna push people to raise the bar as far as funding EMS and things like that, so. It's moving right now. There's still about another month before we'll know if this gets through, but I'm really excited about the potential of this one. I think this has a potential to be a really big deal. And it also springboards into a study, talk about this further and see where that goes and things like that. So, does that make sense? Questions, thoughts on all that? Kind of some of it goes after the, where I'd like to see us go personally. You know, we had that public health commission this last time, and they said, you know, basically they said if you opt in, they set a minimum number that you have to spend for public health on every citizen in your county. Indiana used to be like 48th or something in spending. You know, now they got us up to the national average. I would love to see something like that. Say, you know what, you gotta spend X amount per citizen on emergency services. You know, or something like that. Now, it all gets into the, you know, money doesn't grow on trees, where does that come from? But I think if you look at, I think a lot of citizens look at taxes as this big, you know, it goes in this big black box and you never see anything out of it. I think as a result, if you have a new tax or a new structure or something like that, and you have, you know, an accountable, solid EMS system, I don't think people are gonna push back as much as, you know, we think on that. So that's my soapbox there, but. There's another one called House Bill 1385, and it's basically on payment for ambulance services. It's an interesting bill, there's a lot to it, but it's talking about basically better like quicker and more, I guess, more efficient EMS reimbursement. The trade-off on that is the balanced billing side of things. There's basically saying if this goes through, that balanced billing will probably be minimized or eliminated. So you guys know what balanced billing is? So basically what happens is say I'm in a car wreck right now and I'm on my way home and one of your services drives me to Union. My insurance company can say, well, you know, that's not a network thing for Yazel. He lives down in the middle of nowhere, Southern Indiana. So why is he running around there? You're not in our network, so we're gonna charge you, you know, we're only gonna pay you $500 of that $1,000 bill. And then you could balance bill me for that other $500. And it makes citizens mad, man. It's like, I didn't choose who came and got me. You know, there's no choice in that matter. You know, if you have 3 or 4 hospitals you can go to and you pick one over the other and that's out of network, all right, I can buy that a little bit, but EMS wise, like, you know, you don't get to call 911 and say, this is who I want. You know, you're gonna get who you get typically, right?
EMS is never considered in network.
Right, yeah, but it's and then the balance bills what I do, and then the other thing they're doing that this is trying to combat is sending the patient the check and then having them pay the EMS service. That happens as well. So like they'll say, yeah, we'll cover your $500 bill. Here's $500 for your bill. You know, and patients are like, no, I'm going to the boat with it or something. You know, they're not paying it. So anyway, it's trying to kind of level the playing field on that, and it's got some fairness side of things too. There's some mobile integrated health bills going out there on trying to get reimbursement for mobile integrated health. That's been I guess a thing we've really been pushing on for a long time, making some headway on. We want these programs to be sustainable. You know, that map up there in the corner, that's something I'll talk about here in a bit, but those are our mobile integrated health programs across the state. They're still almost all grant supported. You know, you're just living paycheck to paycheck on grant renewals and things like that. So if, you know, grant funding goes away, so do those programs. And, you know, these are becoming more essential programs in those counties that they're serving. And so we really need to figure out a way to make them more stable long-term. And that's what the goal's been. Now, that's a little bit of a challenge because the state Medicaid agency had $1 billion shortfall this past year. And so I'm supposed to go to them and say, yeah, I need you to spend, you know, give us a lot of money on reimbursement for this at the same time that, you know, they're $1 billion in the hole. So you can see that's probably a challenging negotiation to have right now. So I don't know that until the dust settles from all that we'll get a lot of movement. But even just this bill going through, that's basically going to create a pilot program with 3 of our county mobile integrated health programs to see what reimbursement looks like and stuff like that. It's not the biggest step that we wanted a bigger step than this basically, or, you know, advocates of mobile integrated health did, but it's a start. And I think it's going to be a nice thing if we can continue to push that through. And just because there's 3 pilot programs, the other thing we've talked about is, you know, we want to continue to aggregate data from all our programs so that we can go and say, hey, this is what it looks like. So that's another one. That's, you know, one of the other big ones we're following. So next thing we're doing right now as a state is really trying to improve our data capacity. Right now, like, I don't know if you guys have dealt, we don't have a lot of great data. And we're wanting to do all these new initiatives, programs, things like that. Like you're talking about, like push those pressers. Say we want to do an initiative, you know, statewide on that. You know, what do you need first before you do that? Need baseline data on what things look like so that if you do something, you know, like a big grant program or something like that, you want to be able to show improved outcomes, right? One of our biggest weaknesses as a state is we have trouble extracting enough data for various reasons to give you those baselines and things like that. And we're really working on ramping up our ability in that area. So one of the biggest things we did, and I don't know, did you guys get any surveys or deal with the workforce study things? The Bowen Center out of Indianapolis, which is like the big public health kind of data, I guess, organization in the state, it just finished the first step of a major workforce study for the state of Indiana. And we have more data now than we've ever had in the history of that as far as what our boots on the ground, day in, day out workforce looks like. It's broken down by county and everything. So it's really good. And it's not just a snapshot. So when you go to do like license renewals in the future, I know it's annoying, but you'll have like 10 questions or 15 questions that you have to say like, yay or nay to, so that we can continue to get this data. And what I think that is like, this is invaluable to us. So really small price to pay to answer, 30 seconds, 2 minutes of questions when you renew, so we can do all this. Because again, when we go to like a state legislator and say, man, we're struggling from a workforce side of things, they're hearing that from every sector under the sun. Everybody's saying we don't have workforce. But when I can give them concrete numbers and attach it to something as, high acuity as EMS, then all of a sudden you're very, very effective. So there's a lot of educational data in there as far as like training institutions. It's broken down by like pass rates and things like that. Paramedic pass rates. It's a really good report. I have a link to it, so I can get it to Barry to get out to everybody or whatever you want. But it's an interesting read. It really is. So, and yeah, it just talks about all sorts of. This was kind of interesting. I thought it shows what EMS personnel holding other healthcare licenses. Long-term care. I wouldn't have guessed that. But that's some of the other things are a little more expected. But that was one that surprised me a little bit. And then people talking about this other thing is, why are people going out of EMS? And they're talking about issues with CME, which I don't think our CME stuff's. There's some hassles there, but it's not terrible. But a lot of people don't like our CME process. Low wages, that's not really surprising. Physical and mental health issues, these are all things that we know, but it helps to have those quantified out for when we look at making initiatives and stuff like that. The other thing we just started on is a major behavioral health data project as far as EMS runs related to it. I know, at least, I don't know how it is for you guys, but some parts of the state, like they're transferring, I always say, when you talk about workforce, when you have a EMS service that gets called out at 2 a.m. to do a 6-hour round trip transfer to, some other part of the state for a behavioral health run, they're probably Googling other professions the whole way home, right? Nobody wants to do that. It's a challenge. And even on my end, like in my community ER, certain types of behavioral health patients will sign in and my stomach drops. Because I'm like, God, I hope they hit the red box before they came in, because they're gonna be sitting here for about 48 hours before I can find somewhere for them to go. That's a problem all over the state. We already know we do 80,000 behavioral health related runs a year in the state of Indiana. And so we're looking at specifically the interfacility transfer side of those things. What time they go out, what's the length of it? If a facility gets, 100 behavioral health runs and 99 of them are transferred out, then, do we need to be looking at alternative destination decisions or things like that? Just all these kind of things, so that hopefully, number one, we can demonstrate the problem from a, initiative-based side of things, but also just, look at it at a very granular level so that you can help adjust your protocols and processes and things like that. So hopefully we get some really good information there. Any questions on all that? We're also looking at, you guys familiar with the CARES registry? Are we CARES here at all? I know there's little pockets, I can't remember who's who. Some people use it. We want to go statewide with that, and that's a cardiac arrest registry, basically. That gives us very good data on interventions, outcomes, and things like that, with all things out of hospital cardiac arrest. Kind of again goes back to the baseline side of things. Also, I think it encourages some friendly competition. I know in my area, if some other county that's about our size starts kicking our butt and out of hospital Ross, I'm like, oh, it's not gonna go that way. We're gonna try to figure some things out here. So, I just think it raises the bar for everybody. It just gives us again some of that baseline data that we're looking at. So you get nice little dashboards and things like that. So we're also working at on hand tabbing. I feel like I've been talking about this for like 2 years, but it started out as a cooperative project between the Department of Health and Homeland Security. Are you guys familiar with hand tabbing at all? It's an app that helps with like pediatric protocols and things like that. Basically, the goal is to minimize at least medication errors and increase protocol utilization. you know, if you're not comfortable with your protocol and you're on, somebody needs a medicine, you're not gonna give it, right? Last thing you wanna do is, you know, withhold pain medicine dosing on a kid with a, you know, painful condition because we're not comfortable with the dosing, right? Antevi helps with that a lot. I use it on my peds codes, like in my ER. We've got a couple medics that work, you know, in the actual ER. As soon as a peds code comes in, I pull them in, I'm like, pull up Antevi, let's get that on board, so. Still working on what that looks like, but hopefully by this summer, it'll be out. It's gonna be more of just a straight Homeland Security initiative, which is, it's okay by us. It helps us to get things out there a little more efficiently. Couple other things, there's a company called Biospatial that basically uses some of the state EMS data for research projects and some things like that. But on their trade-off for access to that data is they give us back a lot of baseline data and things like that. And same thing, it's very, dashboards and all the things that we like to see. My problem is we use ImageTrend, right, as our data repository, and it's this huge like black box of data. And sometimes it's really hard to extract things out of it that are useful on the day in, day out basis. So we have this huge thing, but we can't, and every time I'm like, hey, can it do this? They're like, oh, you have ImageTrend 1.0 and you need 2.0 and things like that. So this will actually help us get better data out there and things like that. So that's it. I know data's not, I'm talking about legislative stuff and data, like you're probably like, man, I'm probably about to fall asleep, but it is important, I think, from our operations side of things. Any questions on that? Fire away. I'm not, like I said, for somebody who said I don't like to stand up here and hear myself talk, I'm doing a lot of flapping my jaw, so. Any questions on all that stuff? All right, well, I kind of meant to touch on this a little bit, the Governor's Public Health Commission. Now they've changed it to Health First Indiana. And basically, like a long story short, they've increased their public health spending per person. And what they did is and then they sent it out individual levels to the different counties, basically population based. More population you have, more money you get, sort of thing. And what they did is they, along with that, to qualify for the funding, they said you have to meet these key performance indicators. Well, EMS, especially mobile integrated health side of EMS, does a lot of those. So one thing I've been telling everybody is reach out to your health department, say, hey, what are some of those key performance indicators that you could use some help on? Let's talk about this. Maybe there's a potential for some partnership. And I know I'm a health officer down in our county, and like the state is really pushing, like this shouldn't just be funding that goes to the health departments and then they just keep it and do it. They want the health departments to be reaching out and forming partnerships with some of the local healthcare providers, your EMS systems. There was a big thing that went out on need to be getting your hospitals to the table on this. I don't know if you guys have heard any pressure from the union side of things, but yeah, we're supposed to be, your local health department's supposed to be reaching out to you guys on, hey, how can we partner on some initiatives and things like that. So not everybody opted in, but almost everybody did. I think there 6 counties that didn't. The other side of it too, though, is they did that at the individual county level, but they also, that's reaching out to your local health departments. The reason they got into this and actually started working with EMS, it used to be if you asked public health about EMS, they didn't know anything about how we worked or anything like that. And these partnerships are really starting to grow for several reasons. Some of the public health leadership in Indiana is medicine physicians, and that's really helped kind of change that dynamic because they inherently understand the EMS system better. They also realize like our public health system won't reach its goals without a strong EMS system. You could argue that almost every EMS run is some sort of failure in the public health system. Talk about stroke stuff, uncontrolled diabetes, hypertension, things like that, overdoses, mental health supports, there's just all sorts of, you could make an argument for almost any kind of run. And then on the flip side is, we need EMS system, we need public health, right? What do we get tired of? We don't mind running on these high acuity runs. It's the high, heavy ER utilizers and things like that. Those folks are the ones that could be serviced by the public health system as well. So it's a natural partnership that I think only needs to become stronger. They realize that because in the course of all their funding that they got, they put EMS in this too. And like, it always makes me laugh because like 10 years ago, we never would have got a sniff of this funding. And now they gave us a lot of money for different aspects. A lot of it's workforce related stuff. So you guys have probably seen some of these grants come out, like PI training, scholarships for workforce, getting students into chairs. Also test prep. You know, I flashed up that thing earlier on some of our pass rates. There's a lot of variance across the state. Some places have really strong pass rates. Some are pretty atrocious. And so they're gonna help, there's grants coming out to help some of our students, do test prep to, you know, one of those where it's like, you know, you get all these questions and if you go through it, you know, if you don't pass your test, you get your money back sort of thing. Just to get our, you know, to get our pass rates up, training materials, things like that. And then some other things that are focused on them, 911 interoperability. That's coming through like the trauma commission side of things. That's where we have a lot of great systems, but they don't talk. They don't talk to each other very well, right? Like if you're right on a county line, sometimes those two dispatch systems don't talk to each other. You may have a, you know, you may have a wreck that's, you know, a half mile into the adjacent county and there may be a unit right there that doesn't even know it's happening because they don't talk to each other very well. Typically, classically, who's the best one that's helped bridge that gap? I would say it's our volunteer fire guys, right? They're the ones who know, like, they'll get on scene and say, well, hell, I know there's a truck sitting over there at, you know, such and such, and they'll be the ones that instigate that. Well, if there's any workforce that, you know, looks more dismal than EMS, it's our volunteer fire down the road. You know, they're aging out, there's not, you know, the numbers coming through and things like that. So, you know, that's another area that we need to be bumping up our you know, our workforce recruitment efforts and things like that, because they're an absolutely invaluable part of our healthcare continuum in so many parts of our state. And I think it's underappreciated, underrepresented, you know, in some of these initiatives that we do. So. There's a trauma commission. It's kind of like very similar to the EMS commission, actually. It's appointed from different areas. They're looking at the trauma system as a state and how we coordinate and everything. I think we do some things pretty well in our like regional referral patterns. You know, but I don't think we always coordinate as a state very well or and share ideas very well. You know, like the trauma referral pattern from here, you know, you don't get a lot of input on or hear a lot about what Fort Wayne's doing. You know, and maybe they have some great ideas that might be useful here and vice versa. You know, we don't really talk about that and some things. And we need to get good representation there. I think the first round of grants just went out. I don't think anything was south of, I know you guys are right there, but nothing went south of Interstate 70. On the first round of grants. Now, there weren't very many applications, so that's, you know, it's partly on us down in southern Indiana and things. But, you know, we want to make sure that we're getting into all our trauma centers. So, you know, I would think Union should definitely have a big seat at the table in that.
We got shot down.
You got shot down?
Yep.
On your grant?
Yep.
Okay. Well, sorry. I'm not on the grant thing, but,
It's the level, it's not the geography, it's the level.
you went for it.
Three, that's what they wanted us to on the one.
It's fair. I mean, to some degree, but we need, you know, that it won't function as, you know, you can make the argument. I mean, obviously the level ones need to do all their services, but you know, that coordination between the different ones is really important, I think, too. So especially like a system of care level. So, you know, you got sympathetic in me. Now I'm not on the trauma commission. I go all the time and flap my jaws just like I am now, but I'm actually on the commission. But there's a rural transfer pilot that's going on. And we'll talk about that a little bit. And then there's some mobile integrated health funding as well. So talk about education a little bit. And one of the things, you know, as we look at that, is state in-service. I don't know if you guys have got, we do a state in-service the first Wednesday of the month at noon. And basically we start out with some housekeeping, like, hey, these are different conferences that are coming up. So anytime you guys got something educationally that you want me to put out there, just shoot me a message and, you know, we'll get it shared with everybody. We do like provider of the month, so please give me those. I only get like one or two sometimes. A lot of times the day before, and I'm like, man, somebody send me something. And it doesn't, like a lot of times they're always sending me all these like hero stuff where they're, like I got one this way where the guy was like hanging off the cliff, putting chest tubes in and stuff. It doesn't have to be that. It can be, you know, this person always is willing to help out and stuff like that. You know, anything, you just want positivity out there. I always say, like, one thing that hit me not too long ago is I was working at our level 1 down our way, and this medic called in with an absolutely pristine report. I mean, just spotless, fantastic. We bring the patient in, the patient was pretty sick. You know how it is when they first get there, this big flurry of activity, and then all of a sudden things kind of settle down when you got all the initial stuff done. And so when it did, I said, who was that called report? And I mean, her face went white as a sheet because she has never gotten positive feedback, I think, ever. And I was like, no, you did a great job, but I scared the shit out. She thought she was gonna get her butt. She really did. And I'm like, that's sad that we're so conditioned to negative feedback that we're actually like throwing off when somebody wants to like say, hey, good job. And that's one thing we're trying to change. And sometimes I provided a month stuff, it can be cheesy, man, but I want to just recognize people for doing good things out there. I think that starts at every level, local, state and things like that. So I want to make sure. So please give me those, anything. Like I said, doesn't have to be anything super fancy. It can just be a nice pat on the back. Thanks for picking up my shift when I had to go to a wedding, or whatever it looks like, man. I want to make sure we're getting it out there.
Dr. Yuzu, you said the first
First Wednesday of the month at noon. Is it noon?
is it Teams or is it?
It's a Teams link, and what you can do, I have a distribution list, so I probably shouldn't say this, but a few during COVID, somebody like hijacked one of our county meetings, and put porn on there. Yeah. Now, to see like the little faces, like all our county guys are like pretty old, like, they're like, and I wouldn't know either, like they didn't know how to get, so it was like 10 minutes. It was like because nobody knew how to take control of the meeting back. So like, I'm super petrified to just like put the meeting out for Joe, because I know I wouldn't have a prayer figuring it out either. So, it's like, we're all just gonna watch some stuff here. So I actually keep it a little bit locked down as far as I don't just put it out public for anybody. But I have an email distribution list that I send out as a reminder about a week before. So if anybody that wants to get on there, just shoot me an email and I'll put you on the list, things like that. So. It's probably over paranoid, but like, I just remember seeing those poor guys' faces and I'm like, I'm glad that's not me. Anyway, that's neither here nor there. And then we do enter your, all you have to do is put your PSID into the chat and we put it in the Cadus right away. Credit for it, so. And we had some good topics, like there's Tim Pullman, who's a trauma surgeon, to this last one. He's really, really good. And stuff. So it's just a nice way, and it's a nice way to share ideas and things like that. So we've been doing it, I guess it's probably pushing a year now, but started really slow, 15, 20 people. And now we get about 100 every time. So I'd like to keep building that, just a way to share ideas and again, get input from all over the state, like, if they say the presser thing really, takes off and you have some good outcomes with it, I'd love to say, hey, why don't you come on here and tell us how that works so that and what your protocols look like so that some other services can pick that up. Those are the things I'd like to see come from that. We're doing the regional forums. You guys, have you guys ever been to any of those before? We do about, every other year, it seems like, I think.
Every other year.
Was it?
Every other year.
Every other year. So this is the year. So they're coming this spring. These are tentative, so like, it's a save the date. It still might get changed, and then I think the one we're still looking, trying to get that last date.
We're looking at Gibson for District 7
Yeah.
area. 7 and 10, the Southwest, they wanted something central, because we had in Greene County last time.
Yeah. But I don't think, like, say, if somebody wanted to go to Maid, like, I don't think.
No, they could go any of them.
Yeah, so, but these are the dates for any of those. So if any of those are convenient for you guys, we'd love to see it. It's pretty good. Like, we do we start off with kind of just again, some state updates, some things like that. Some questions we get, clarifications, new rules, things like that. And then the afternoon, a lot of times we do different breakout sessions and things. So we're still looking at the structure of that. So if you guys have anything you'd like to see at those, say, I think would be really, really beneficial. Reach out to us, or reach out to Stan. Say, hey, what have you thought about this? Because we want to make it the best use of your time as well. But it's important to us as a state to get out there and hear what's going on and things like that. So I always say, like, we're starting to build some, at least from a, state supported side of things, some good education activities. I still say that's why I commend this process. I mean, the foundation of every EMS education should be your local audit and review. Talk with your local hospital on, feedback on things and stuff like that. That is the absolute foundation. So places like this that have a strong audit and review, is much appreciated. But, if you talk about the state in-service regional forums, the EMS commission meetings, things like that, you've got a basis for a lot of that CME right there, pretty readily available. So, and we want to make sure we continue to build those. I do hear that. We saw it in the workforce study that there's a lot of, a lot of frustration over the CME process. So we want to make sure that we're getting it as convenient as possible and also not just going through the motions. I don't want something where you're just, clicking through something and say, oh, there's my CME. I want you to walk out of it and be like, man, I'm a better provider. I learned something, really important as a result of that. So any questions on that? Hey, I stole my thunder on the trauma commission, so we'll pass it. But this is where we start looking at that rural interfacility transfer pilot program. So this is some of our areas that are within, or the white areas are greater than 45-minute drive to a level 1 trauma center. Or actually, maybe a trauma center in general, I guess.
Mhm.
I still think, yeah, it's trauma center. I still think some of the,
It's any trauma center, isn't it?
yeah, I think you're right. Yeah. I still think some of those are off a little bit. Like that far southeast corner, I still think I may even get to University of Cincinnati a little quicker from some of those. But in general, these are the areas that are hard to cover and things. And so what we're doing is looking at some interfacility transfer pilot programs to plug those gaps. And we actually have some pilots that cover at least in some portion of all 3 of them, those bigger areas there. And I don't know, when it's interfacility transfers can be a real challenge. Because you're trying to accommodate, especially places that do 911 and interfacility transfers, right? Especially a rural system. I always say your choices are, you get called by the hospital to do this transfer. Okay, you take it, maybe it's a couple hour round trip. What happens when a high acuity 911 call goes out? You can't win either way, right? You got the hospital mad at you on one end because it's taking too long to get this transfer out. On the flip side, the next day, the commissioner's in your ear because his grandma, had to wait an extra 15 minutes to get her 911 call. Can't win. And it's hard, there's especially in some areas, and especially our rural areas, it's hard to get enough volume from a transfer side of things because everybody's like, oh, you just got to pull it out of 911 in general. That's great to have a truck that's going to run 3 times a day. It's not financially feasible. So we're looking at ways to support that on kind of a regional level and things, but also not step on toes of systems that are doing it really well already. There's some places it's an absolute nightmare. I had a head bleed I work at a level 1 and a community ER. We had a head bleed that sat there for 12 hours the other day because we couldn't get them out of there. So there are some pockets where that's really challenging. And so we're looking at, I call them rapid teams, and it stands for Rural Access, Interfacility Transfer, and Didactic teams. And basically what they're gonna do is help get, they're gonna say, we're gonna cover this specific area. It's gonna kind of be spokes on a wheel of critical access facilities. And you say, okay, if you have a transfer, I'll come get them from your facility and take them to a destination place. And they're gonna cover a much broader geographic area, and instead of 1 critical access place, 4 or 5 of them. And then try to help get those patients out and study our outcomes and things like that as well. So that's basically what it looks like. If there is downtime, then we always say they can do some community paramedicine and then didactics as well, because I think our flight services are really good about, going into local ERs and augmenting educational opportunities and things like that. And I think with these rapid teams, there's a potential for them to do those in those critical access hospitals that they're serving as well. Hopefully they're, so busy helping these other critical access places getting out that there's not a lot of free time, but we want to make sure that they're, utilized well and things. So that one is coming up for bid here very soon. The main 2 areas, and this wasn't, I want to do 6 teams, but obviously that's a pretty big budget fight. So we got to do 2 teams, and one's going to focus on that far north central part of the state, and the other one's going to focus on the southeastern part of the state. So it doesn't hit this, but there is a Rural Health Association kind of sister project that's going to be involved here. That's going to have somewhat of there's going to be some bells and whistles that are different, but to some degree, sort of the same goal. And the nice thing is we're working kind of simultaneously and sharing ideas and things like that, because there's going to be aspects of this one that work, and doesn't work on mine, and vice versa, and things like that. So hopefully we get some good. And then the other side thing of this is the billing will be open books. So I can say, okay, it costs this much to support this program. It brought in this much. So what's that gap look like? So that we can start advocating for better reimbursement. Because again, we all know that if reimbursement was appropriate on some of these transfers, it wouldn't be such a problem. So anyway, I think that's I'm excited about where that's going, and hopefully we'll make a change. And that's one of my biggest priorities for this year in general is just kind of looking at the whole facility transfer process in general. Do we need to regionalize? Talk about tiers. I think you say tier A is your ones that essentially are 911 call. Some of these ones you're talking about from the trauma. You got bilateral pneumothoraces with chest tubes and, 300 cc's of blood. I mean, that's essentially a 911 call. They need to get, they need to get out of your ER with the same urgency that they get picked up from home. B is maybe these ones that need to go to a definitive care center, but they're not gonna get an intervention in the first like 6 hours, I think those are the ones that tend to really get burnt right now, because like they need to get there, but it's like, there's not as much urgency. We know outcomes are better sometimes being at a, definitive stroke care center or a, trauma center or things like that. But, if they're not getting surgery right away, there's not necessarily the same urgency, and those tend to sit a long time. And then C are the ones that really could go out anytime, like some of your behavioral health ones or things like that, where they need to be where they get to be and deserve to be where they, to their destination facility, but there's not a level of urgency there.
So
And
is
looking
the
at how we
state
handle
looking
this.
at the rules then for trauma, because the state has the trauma rule 120 minutes, and it's not gonna happen, especially not here, because we only have one service that can provide that.
Yeah.
So are they taking that into consideration when they're looking at all this stuff?
So that's what we're
Because
doing.
we talked about it in trauma, and they're like, nope, we're not gonna get rid of it, but they're not gonna modify it either.
Right. And that's the thing we have to look at is I think right now, we put all these things up there that are like, this is in a perfect world, this is how things are gonna be, but we all know that it doesn't really work that way sometimes. And so I think we need to say, okay, this is what, what it really looks like. Cause I don't think that always happens, and it's not feasible to happen sometimes.
Because that
Right.
double chest tube guy flew out,
Yeah.
so that was a little easier to control.
Right.
But the oxygen smoker lady went by ground, I think, or whoever, we have a lot of those ground ones. And I look over there because a lot of these guys are the ones that are taking them. They're the 911 backup, and they're the private service, and they're for both hospitals.
We are 911 county.
Yeah.
Well, to go to, where'd that one end up? St. Vincent, I think?
Yeah,
So what's your last assigned to St. Vincent, you're what, pushing an hour, 45 or something like that?
yeah, I guess.
But it's like no big order anyway, right? They can't hardly, so, yeah, I think that's the thing, is just take a deep dive and look at it and say, what can we do to support this instead of, because right now, I mean, it really is, when's the last time you had any real help from the state on any of that?
I've been in this role 7 years, and I don't think we've
Right,
ever.
that's what, and I'm not saying that we can come in there and be like, here's our EMS service for everybody, but like, there should be things, we say we want these outcomes as a state. Well, either we need to get, boots on the ground at the granular level locally and help people, or figure out some ways to regionalize or what that looks like, to be honest. And I don't know I lost Dr. Worley, but like, I know sometimes, for me, like I have to call around to like 10 or 12 different facilities. That's actually why I asked about the burn beds, because I know those can be hard to come by. And like, in the ER, here you are calling like, 10 or 15 different places, in different hospital systems, trying to find an accepting place. And then when you do, I mean, my God, that bed is worth its weight in gold. And then, but they'll say, well, but if you got to get them here in the next, next 90 minutes or something, and you don't have that ability, So there's basically what we want to do is look at that and figure out, a better way, for lack of a better term, is to like, figure out, different ways that we can support that. So long story short, I don't know that we'll have all the answers. I think there's been a lot of smart people involved in this over the years, and if there was a perfect solution, we'd probably already be there. But I do think we've kind of just left it to its own devices, I think a lot of times too, without really putting the effort in.
So how are you gonna build the rapid teams though if the workforce is low? Because that's part of these guys' problem, is they don't have enough medics to go around.
So I'll be honest, in some of those areas that we've targeted, I've reached out to them and said, because that was my concern too. It's like, all the money in the world, you can have all the nice trucks, there's nobody to put on them, you're not gonna get there. There are services that are confident that they can meet that, and that they think that, even so one thing I didn't put in this is there are 4,700 licensed paramedics in the state of Indiana. We pulled about a year ago how many had filed a 911 run. Some of you probably heard me say this before, so don't answer, but if you had to guess how many were actually out on the streets. It's about 1,600 out of the 4,700. And so that's why, same thing, they're like, why are you preaching mobile integrated health to everybody? That's gonna pull medics off the trucks and everything too. But what we're hoping to do is pull some of those that have said, I'm tired of just being on the street all the time, pull them back into EMS. And I'm hoping that some of these programs will do it too. I know nobody's like, I went into EMS because I want to do interfacility transfers, but I do think these are gonna be high acuity patients and things. And one thing I would like to turn this into is some specialized training opportunities too. So originally the pilot, when we were looking at having like 6 teams, I wanted each one to have like a specialized training that, one be hazmat, one be the, search and rescue and each one, so that if there's an issue anywhere in the state, we can say, okay, we're gonna pull the search and rescue to Evansville because there was a tornado or something like that. And also use this as a sort of a mass casualty response team too, because again, right now, if you said, Terre Haute got hit by a tornado this afternoon, as a state EMS, we can send all sorts of Homeland Security resources your way, but I can't say I have 6 trucks at my disposal that I can send to help out. We don't. In this situation, we could pull all those rapid teams and say, okay, sorry about the interfacility transfers, but we have a higher priority. You're gonna come help out here for a day or two. It would give us some sort of mass casualty response capability too, is where I would like to see that go. I think first, and I was complaining about going from 6 to 2, but at least it shows, I do think we're obligated to show that there's utility there, that they're utilized appropriately and things like that. The idea sounds great to me, but sometimes when you implement those on the ground, there's things that just don't work. So. All right, any questions on that? Very much talking to you.
You're good. We got the room for another 40 minutes, but.
I don't want to say, if any of you guys have, I don't want, I will talk as long as you guys will let me talk, but I don't want to monopolize people's time. So anybody has to go right ahead. But the other thing we're trying to do is integrate ourselves into the 988 response. When you call for 988's, behavioral health crises, overdoses, things like that. Who goes out on those right now?
Yeah.
We do, right? 81,000 times a year. And so they're building this infrastructure to respond in real time for behavioral health emergencies. And that's great. I commend that. I really, really do. They're trying to build this huge infrastructure to respond. And I'm always like, you got it. We already do that. But, we want to integrate those 988 crisis response teams in with like our mobile integrated health teams and things like that, so that, they could respond to some of these, again, our heavy ER utilizers, our heavy 911 utilizers, things like that. I do think there's a role for EMS in that, because we've been doing it, from the get-go. So I always talk about community paramedicine, MIH. That's something I've always been been pretty passionate about. And the reason being is I think it helps all aspects of MIH. Mobile integrated health is one of those where I say everybody wins. The patient wins because by being identified as a potential mobile integrated health patient, they have some sort of healthcare vulnerability that you think can help. You're already taking the most fragile patients in your community and trying to deliver care. I think your local EMS service benefits from it as well, because again, almost every single one looks at the heavy utilizers. I always get asked like, well, where do we even start? I'm like, think of the EMS runs that frustrate you. What ones irritate you? Like, why am I here? Those are mobile integrated health patients, because they are. It's like, your repeated falls, things like that. Get in there, do fall prevention, medication issues, some stuff like that. So it helps your EMS system to filter off things so that you can focus on the highest acuity runs. That's why a lot of us went into this in the first place. And it helps your local hospital and healthcare system, because almost all of them do readmission prevention and things like that too. It helps you with your length of stays. If somebody you're like, man, I don't have a tenuous discharge situation. If you knew a mobile integrated health program would be there in the next 12 to 24 hours, you're probably able to get them out a little quicker too. So it helps the hospital side of things. I'm sure you guys aren't immune to it. Like every place I work has any given time 10 to 12 patients that are admitted to the hospital that can't get upstairs. They're being boarded there. So the more that you can get people out, the more room it is for everybody. So, everybody wins on that. And then the other thing is, like, in general, we're doing a lot of things to try to improve, like, reimbursement and some of the other things that come with EMS. But for the people who are actually in the position to make some of those changes, there's been still very little movement even since the 70s as far as reimbursement goes and things like that. So to all of a sudden think they're gonna have this epiphany and be like, you know what, we've been neglecting EMS all this time. You know what, we're gonna change it all. We're gonna just, pay them appropriately and give them a pat on the back. It's probably not realistic. So what we need to do is look at alternative ways to get ourselves integrated into our community and make us part of the essential healthcare continuum in the community. And mobile integrated health is a way to do that. You talk to a county commissioner, they may not understand, how 911 works. They just think you call and somebody shows up and it's that simple. But they remember like Homebound Hoosier, where EMS came out and did COVID shots and stuff. Did you guys have an active program here? A lot of the commissioners like, that is mobile integrated health. And a lot of them are like, wait a second, now that really works. So if you start ingraining yourself that way and giving them alternative ways to look at EMS, that's how you get a foothold to get some things done. So. That's our map. So still north of 70 kind of thing. We're still starting to build some programs. At least I got my own county in there. It used to be they put up this, because they know I love MIH, and there used to be this big gray area down in my county. It seems like I put this map up, everybody just look at me. They do it like irritated me. So now we have 2 programs in our county, so we're getting there. But the other thing we're doing is talking about, when I mentioned behavioral health, you know, we've talked a lot about our patients, but we need to take care of us. You know, I think, you know, when you talk about mental health for first responders, there's just, I mean, it's kind of been the elephant in the room. Some places have good programs, you know, for support and things, but, you know, in some places it's next to nothing. It's a phone number on the wall and things like that. And, you know, we've got, you know, I always say my most important thing is that you all come home healthy and happy for your families every single day. And it's a tough profession to do that. So if you think about it, we do everything ass backwards in EMS when it comes to mental health. We say, here's this career we're going to put you into, and you're going to do it for a while, and you're going to see things that no human was ever meant to see. And then 6 months from now, when it kind of messes with your head, we're going to tell you what you should have done all those 6 months in order to be able to process it better. I mean, for lack of a better term, that's exactly what we do. And it's starting to, that realization is really starting to change, you know, and we're just not classically ones that engage the mental health system very well, you know, in the first responder area. And that's starting to change. And we're starting to see leadership that's really stressing that and things. We're actually starting to see legislation in that. Last session, there were like 6 bills on first responder mental health. A lot of them didn't get traction because it was like, we all say we need to do it, but then like, what do we do? Like, you know, we want to do mental health, but what's that really look like? So it didn't get a lot of traction. They finally got one through, and that's what it said is, you know, we need to do first responder mental health support is mandatory. But it was that nebulous. So the last thing on earth I want to do is give you guys your 1 hour mental health, you know, CME block that you just, you know, click through. We want to do something impactful. So we're having meetings with like some of the state agencies involved with mental health and look at what that looks like for our first responders. And there's a lot of different, what I consider like the core, you know, components of a EMS, you know, effective mental health thing. First thing is, you know, pre-employment resiliency or training. Like, you know, instead of just throwing you out there saying, okay, these are some things you're gonna see. Let's talk about how you process those. Let's make sure you understand, you know, the mechanism you have at your disposal if you are struggling with something. Peer support. I think nothing, you know, I think that nothing beats that. Just to have somebody who's seen what you've seen to kind of decompress and talk about it. Critical incident stress management. So, you know, when we see a particularly, you know, a particularly rough call or something like that, you know, having that kind of support. But I do think, you know, having some other means of reaching out is important too, because what may be a critical incident for me may not be for you. You know, it may be my family member that I run on just by luck of the draw, you know, whereas everybody else it's another run, but for me, you know, having nightmares and things like that. So being able to identify, you know, what kind of stressful runs may be on an individual basis. So virtual options, you know, just keep it easy and, you know, help with access, especially in our rural areas. And then I see barrier-free access to qualified providers, because very few, when you talk to people in the behavioral health field, very few of the behavioral health providers are actually trained in dealing with first responders. It's a whole nother animal of its own. And there are very few of them that are, and so they may have trouble. It's hard to be an effective therapist for somebody when you don't understand what they do or see in the first place. And so helping build that and linking people to the appropriate therapists and things like that, so. And again, just kind of decreasing the stigma that comes along with that, I think is one of the biggest things. So we're working on putting up best practices together for that, so. I was gonna talk whole blood real quick, and you guys, you can't get through a talk with me without talking about whole blood. That's like my favorite topic, but we have 2 services, ground-based services now, who are doing whole blood pre-hospital. They're using some triggers of mechanism, hypotension, and then, you know, some sort of third indicator, whether that be shock index or end-tidal CO2 or something like that. So they both, I mean, we're talking, they've been up and running like in the last 2 weeks or so. So Crawfordsville Fire over this way, Newcastle is doing it. And then the tactical team for Indy EMS, they carry blood on their SWAT call outs. They've utilized it at least twice, I think. These other services are brand new, and so they're just starting to. I really think this is a way it's, you know, for as far as your major trauma resuscitations, you know, I think this is where a lot of things are gonna go, to be honest with you. If you think about it, when somebody's losing blood and you're replacing it, and I'm not minimizing the need for IV fluids, but you're not replacing oxygen carrying capacity when they're losing blood and you're putting fluids in. And I think especially in your kind of middle range transport times, that's your sweet spot for it. If you're gonna be at your destination facility in 5 minutes, it probably, you know, you're gonna have trouble getting blood going anyway. If you're, you know, if it's trauma that needs blood and you're 45 minutes out, you're probably gonna be flying them if they're flying, right? But it's that sweet spot of your 15 to 30 minute transport times that, I mean, that can make a difference between life and death. And there's some systems, I put Miami and San Antonio on there that are doing that pretty successfully. And I would love to see, you know, perfect world, I would love to see like every trauma center partner with a service or two on just, you're our pilot, you know, be a pilot project so we can get some data as a state, you know, for it. Because I do think right now, you know, with just a handful of programs, we're really gonna have trouble getting enough data to show statistical significance. Like Crawfordsville, I bet they probably, you know, we did some retrospective run reviews with them. They're probably gonna give it 10 to 20 times a year. And I think it's gonna be, you know, and I'm excited about that. I don't minimize that. But to get enough statistical significance to say this definitively works, you know, we're gonna need more like 100, you know, things like that. So we'd love to see some other places pick that up. And we're happy to help show, you know, with protocols and talk about some of the same concerns that I think everywhere has. You know, obviously blood supply is a big concern. There are some studies that show getting blood on board early actually saves blood use at your destination facilities. And then also, you know, we've always said, we're gonna ask for this as an EMS service. We're gonna do the legwork on our side, you know, and increase community blood drives, donations, things like that. We said, you know, if we don't give our blood on our end, then we don't get it back to give it as a community. And, you know, I think when you put a blood drive out there right now, people will show up and things, but they don't see it as coming back in their community. I think if you said, you know what, we're gonna do a blood drive here and those blood products are gonna come back to your community as an initiative for your local service, I think people line up out the door. I really do. And I think if we put those in place, we can increase our blood supply as a state as a whole, not just in these pilot areas. So it'll have an overall positive effect. So that's my soapbox on that. That's probably long enough. So any questions? This is your fair game time to ask anything you want. Things you'd like to see us do as a state, things we do right, wrong, or anything, man. It's speak freely.
Thank you so much. Appreciate it. All right, guys.
Oh, the last thing, please keep inviting me to these things. I love to get out, talk. Any of you guys who do things with your local services, anytime, you know, I can help with anything, please reach out.
All right, couple things.
Yeah.
Housekeeping things. I put this on here for you guys to sign in. Please sign in the sheets if you have not signed. If you're in person, I want you to sign in the sheet up here. There's a sign-in sheet up here. If you're watching this will be back on YouTube, my YouTube page, probably within the next couple days. So you need some more updates and some other things you might need. But this will work. I figured out what button I wasn't clicking right the last time, so this will work, I promise you. So talk about a little bit about protocols. This is kind of an advisory board update, advisory board update. You all saw what we're actually gonna be adding push dose pressers. There's some other changes, some significant changes to the protocols we're gonna be doing. Those are come out today to our group. We're gonna review them, go over them, probably by the middle of March. The protocol test will be ready. You have to take the protocol test. There'll be one test if you're an EMT, there'll be one test if you're a paramedic. But the paramedic one will have EMT, advanced and regular and paramedic questions on it. You will all have to take the paramedic test, the protocol test, period. We want to implement the protocols, what we say, first part of April-ish, may give a month or so to do the testing. I'm going to build the test in forms like this. So there will be a QR code and a link, so you'll be able to go out to the paramedic test and the protocol test and take those. I will then get a record of them and I can keep track of who, and I will let the services know every other day or weekly or something, who's taken the test and who has not taken the test. Does everyone understand that? Yes, ma'am.
There one designed just for the advanced EMTs in the county? Okay.
Yep. There'll be one for advanced, there'll be one for, and somebody asked earlier in the advisory group to try to build one for EMRs too, because we are 20 BLS and ALS non-transport. We're the medical director for those. I'm going to require all of those services to take the test also. If you're gonna use our protocols, you need to know the protocols and you need to be able to test them. So give you time, but you obviously will have the protocols to go when you're taking your test to go into and look at. It's an open book type situation. Any other questions on protocols? Anything from the advisory board that I missed? Well, hey, please sign in. Thanks very much. Have a good day.
I try. Okay, I'm gonna need you with this.
Go.
I am pretty sure I know the answer to this question.